Hi, everyone. Good afternoon. Hey, my name is Aravind. I'm a pulmonologist. I mostly practice in the domain of interstitial lung disease. And I get really nervous talking to patients. Like giving a talk to students, to fellows, to my colleagues is not really that challenging. But talking to patients is challenging because you're the ones who live through these diseases day in, day out. You're the ones that matter. You're the reason that I went to med school. And you're the reason that I am continuing to work and go to clinic and go to the lab and do everything that I want to do every day when I wake up. So with that being said, I'm going to talk a little bit about scleroderma and its manifestations in the lung. This is going to be very informal at any point of time. If you have questions, I'm happy to stop, take questions. If you have clarifications regarding any of the information, I'll be happy to expand more. And if I don't know, which is mostly not that uncommon, I will get back to you with stuff that I know or I find out. Hopefully now, not the future. All right. With that, all right. These are my conflicts and disclosures. I do serve on the advisory board for a few companies and do some consulting and CME talks for them. I am funded by the Chess Foundation through their grant in pulmonary medicine for my research. So I usually start all my ILD talks this way. ILD is a field where our understanding is evolving. We know more about it now than we did 20 years ago. There is still much more that we need to know. And I'll probably have this preface if I'm doing this 10 years from now. This slide's probably going to find its way there. To just give you a kind of framework on what we're going to talk about today, we're going to talk about the overview of ILD, what it means, because it's an alphabet soup. It's not something that we make it easy for the physicians, the trainees, or the patients, because we just like spurting out different letters of the alphabet and say it's something unique. Or we try to think it's something unique, but maybe it's not. So we'll talk a little bit about that. We'll talk about the prevalence, the impact of the disease when it appears in scleroderma, the treatment, some of the evidence behind the treatment. And then I would like to take some time to get your input to see what are your unanswered questions, because I get a lot of them when I see patients in clinic. And it would be helpful as both as a clinician, as a physician scientist, for me to know what are the questions that you want the answers to, because that is what we should be focusing on. And I'll touch a little bit. I know that Dr. Baker Frost is talking about research updates, but I will just give us a little bit of an update on what's happening on the pulmonary front. All right, ILD, what is it? And this is one of the most common questions that I get asked. And the framework that I have come with to answer that question is, it is a group of different diseases that have a shared behavior. And so if you think about ILD, there are about 200 different etiologies, or 200 different diseases that kind of get clumped into that bucket. And why do these 200 diseases find their way to one kind of grouping? And that's because of one, where in the lung it affects or it manifests, and two, its potential to cause pulmonary fibrosis. So the Venn diagram that you're seeing there, you can see most of the more common lung diseases like COPD, asthma, bronchitis, cystic fibrosis, those are mostly airway-based diseases. Interstitial lung diseases refers to the interstitium, and that's what you're seeing over here. What does this look? Oh, maybe not. Okay. No. So this is what the interstitium refers to. So this is the actual barrier between the alveolus, the air sac, and the blood capillaries that take blood through the lung. So the whole point of why we have lungs and why we need to breathe using our lungs is because it provides the unique interface where gas exchange can happen. And that gas exchange happens through the interstitium. And that's when disease affects that space, it is that group of diseases get called interstitial lung disease, and that's what causes some of the symptoms that we see associated with interstitial lung disease. Now you can see on the Venn diagram that interstitial lung diseases are a bigger circle, and pulmonary fibrosis forms a subset of that. And that's because there are interstitial lung diseases that don't always cause scarring. or there is going to be some variability in how they behave. So not all interstitial lung diseases necessarily cause scarring, but a lot of them do, and all of them can potentially do it. This is the classification of interstitial lung disease. I leave it up there again just to share the complexity. I don't expect any of you to follow this, but it is one of the things that I talk to my fellows and I say, this is a classification that was born out of convenience. It is, you can see there are different diseases that are clumped together that necessarily do not match from their disease etiopathogenesis, their risk factors. But this is kind of born out of convenience as to so that we can at least start to identify and kind of study them in groups. And this is the definition that came out of Travis and Costabile in 2013 ATS guideline. So talking specifically about scleroderma lung disease, the understanding right now is that the interstitium that I had previously shown gets affected with inflammation, and the risk factors for inflammation in scleroderma are many. And as you all know from what Dr. Silver and the other speakers have shared, we are still learning to find what is the specific switch. Why is it that this group of individuals who have a certain genetic predisposition, certain environmental exposures, why do they develop this disease? And why do others not? And within the group of patients with scleroderma, is there something that increases their risk of developing lung disease? And there are some identifiable risk factors that I'll talk about, but at an individual level, it's not yet something that we can predict. So through the course of the disease, there is ongoing inflammation, just the same way that happens in the skin. There is inflammation in the lung through multiple mechanisms leading to fibrosis eventually in the lung. Now, this is a map showing the prevalence of interstitial lung disease across the continental US. And I put this up here because it's something that stands out. So within South Carolina, you have, per latest estimates, and this is data coming out of IHME in Seattle, the highest incidence of interstitial lung disease within the country. And when I moved here from Boston, and this just caught me by surprise, because the amount of pathology that I was seeing in my clinic was manifold than what I was seeing in Boston. Initially, I thought it's because in Boston there were multiple specialists and they would all, we could share the patient population, but that's not the case. There is more disease here. This is a compilation of pulmonary sarcoidosis and interstitial lung disease, which may skew the statistics a little bit, but nonetheless, we are seeing a higher incidence, higher prevalence of disease in the Southeast. So again, talking about the various factors of how the inflammation manifests within the lung, you have tissue injury, you have vascular injury, and you have autoimmunity. Again, all leading to the common final pathway of what inflammation leads to in the lung, be it infection, be it autoimmune disease, which is scarring. And unfortunately, scarring in the lung at the moment is incurable and irreversible. How do patients come to me? They come with symptoms of cough, dyspnea, fatigue. And how do you get diagnosed once you have this? It's through a physical exam. All our rheumatologists who our patients present with initially, sometimes they come to the pulmonologist first with the symptoms. We listen for crackles. We listen to your lungs. We listen to what has changed. What were you able to do 6 months ago that you're not able to do now? Is there anything else? Are you bringing up any sputum? Pulmonary function test gives us a quantification. It gives us an objective measure of how much or how well your lungs are functioning. And the gold standard of identifying any form of interstitial lung disease is a high resolution CT scan. Which brings us to the question, who should get a CT scan? And here is where the guidelines kind of differ or are in evolution. So these workflow that I have provided here is actually from the 2023-2024 CHEST and American College of Rheumatology guidelines on screening for interstitial lung disease. And there is a subgroup of patients with various forms of various autoimmune diseases or systemic autoimmune and rheumatic diseases, SARD, that we recommend getting a CT at diagnosis. And systemic sclerosis is one of them. Now, the data behind the utility of that or the pitfalls of doing a CT scan in someone who's asymptomatic with systemic sclerosis is not yet borne out. So there is still some conflict and contention of these guidelines. The British Thoracic Guidelines also, the British Society of Rheumatology also has similar guidelines. What does interstitial lung disease look like? And I've given you kind of a snapshot of different CT scans that you can see within a spectrum of interstitial lung disease. From the top here, whoops. So just to give you a frame of reference, this is what normal lungs look like on a CT scan. They're black because they're filled with air. And in a CT scan, the lungs which are filled with air have this kind of grainy black appearance. You'll see these little white lines that course through it. Those are the normal blood vessels that go through the lung. However, what is abnormal is seeing these faint areas of white. And these are what, if you have ever looked at a CT scan and have seen somebody call it a ground glass opacity, that's what this refers to. And so I'm giving you 6 examples of what scleroderma interstitial lung disease can look like. Most commonly, it is going to look like this one, the one that I'm moving my cursor over. That is called a fibrotic NSIP pattern. And these are, again, scientific terms that we use to kind of classify and try to understand why and how each patient is different, and not everybody who has scleroderma interstitial lung disease is going to behave the same way. Because what we are seeing here is much more of an aggressive form of pulmonary fibrosis. More of the lung is involved. We are seeing what we call honeycomb change, which is essentially end-stage fibrosis. Here we are seeing what we call cyst-like changes. Here you're seeing organizing pneumonia, and this is what we call pleuroparenchymal fibroelastosis. So again, kind of like the reason that I'm sharing this is to kind of tell you, even within that one etiology or one topic of scleroderma interstitial lung disease, the disease can have many faces, and not all of them behave the same way. This is the global prevalence of systemic sclerosis that we know from review article in 2019. Again, this is not systemic sclerosis ILD. This is overall systemic sclerosis, and this is incidence per 100,000 individuals. In the US, you can see it's around 13.5 to 39.9, but accurate estimates are always challenging with rare diseases, as you all know. But looking into what's the proportion of patients who do have interstitial lung disease with the diagnosis of systemic sclerosis, and there are certain risk factors within systemic sclerosis that increases your chances of developing interstitial lung disease. But we know somewhere around 30 to 60% of patients with systemic sclerosis do develop some form of interstitial lung disease during their disease course. This is, again, a little bit older data that looked at the incidence and prevalence. You can see from 2011 to 2016, again, saying that this is about 9 years ago now, you were seeing kind of a plateauing in the amount of systemic sclerosis prevalence, while you're seeing a slow uptick or a slight uptick in the ILD prevalence. I suspect this, we are waiting on more updated data to come forward on current estimates, because we suspect this may have changed with increasing amounts of people who are undergoing CT scanning, as well as lung cancer screening and other incidental ways in which interstitial lung disease is being picked up. I mentioned risk factors for developing interstitial lung disease in scleroderma, systemic sclerosis, and epidemiologically, we have found some clinical examination-wise, we have found some risk factors, including diffuse variant, presence of certain antibodies that we test on the clinical front. We can kind of say you're at an increased risk of developing interstitial lung disease. Now, does that necessarily translate to an individual, to a patient? Not necessarily, right? Like, as in, I can just tell you you're at an increased risk. I'm not able to quantify what is the percentage chance that you have of developing interstitial lung disease. So what happens? What is the impact of interstitial lung disease in scleroderma ILD? And so this is, again, a simple graph that is showing distribution of FVC within a normal range. So the green refers to normal lung function as measured through this variable, which is the FVC, or forced vital capacity, is the amount of air that you can voluntarily move in and out of your lungs. You take a deep breath in, and you breathe out as hard and as fast as you can. If anybody has come to see me in clinic or a pulmonologist in clinic, you would remember how hard that maneuver is, but that's what we are measuring, right? And if you look at the three kind of categories of this, you see people within more than 100% of what we predict them to have. the amount of air that you're moving, 70 to 100%, and less than 70%. And you can see how that distribution falls across patients who don't have any scarring. You have a higher proportion of people with normal or intermediary lung function as compared to those who have at least 10% fibrosis on a CT scan. And you know that that scarring is kind of having an impact on your lung function. How does it matter when it comes to survival? And this is a graph that is showing the impact of each of the features that you can kind of clinically discern within systemic sclerosis. And what you're seeing as SMR on the x-axis is standardized mortality ratio. So you can see there is a wide confidence interval with PH-ILD, but you do see that that's one of the highest risk factors when you have both of those things together, pulmonary hypertension and ILD. Looking at how standardized mortality ratio within the ILD framework, one way of looking at it is like we know that ILD translates to FVC or change in your lung function, and how a change in lung function translates to mortality. And you see the lower that your FVC is of predicted percentage, that translates to a higher mortality risk. This is a snapshot of the heterogeneity or the diversity in lung function trajectories within a scleroderma population. And you can see that there are folks whose FVC or lung function improve with treatment. There are folks who don't have any change over time. This is over 5 years, and this data is from the USTAR database between 2010 to 2015. So it is from the European population. And then you have folks who have, they have an uptick, then a decline. Then you have folks who have a downtick and then kind of plateau out. And then the dotted red line is the ones who have a progressive decline with no improvement. So again, this is an example of how, when you come to see me in clinic, you ask question, who's going to have, which trajectory are you going to take on? It's going to be difficult because right now I don't have tools or predictive elements that I can tell you, this is what I expect for you in the future, which is why we see our patients at close intervals with repeat testing. Now, previously we thought that, scleroderma that was diagnosed within the past 7 years, that is the most important when you capture them in the acute phase. During the first 7 years, you kind of have the disease evolve, and later on, you don't necessarily develop additional manifestations. But this data, again, from Anna Hoffman-Wall, we see that even in patients who had a diagnosis of systemic sclerosis more than 15 years ago, we are seeing evidence of lung function decline. And that is this group, if you can see here. And it is a smaller percentage, but it is still a feasible percentage of between 10 to 15% who can develop interstitial lung disease even later on into the disease course. Survival, again, recapitulating the same data of fibrosis versus no fibrosis. Clearly, presence of fibrosis associated with poor survival. And stable fibrosis versus progressive fibrosis, one would expect someone who has progressive fibrosis will have a lower survival as compared to somebody who has stable fibrosis. Let's talk a little bit more about treatment paradigms. And I wanted to talk initially about the non-pharmacological, and these are oxygen supplementation and pulmonary rehab, two of the things that we know improve mortality in interstitial lung disease till date. Oxygen therapy can take on many forms. There is the home concentrator, which is the big machine, the one that does not move around. There is the portable concentrators. There is different forms of tanks. The most common one would be an e-tank, which with a regulator on top that can give you continuous flow up to like 6 liters for up to maybe 2 hours or so. The delivery devices can change between nasal cannula to oxygen mask, and you often see a humidifier usually associated with this larger unit here to make sure that the nares are not drying up. Oxygen therapy, when and who, and this is data that has been extrapolated from different lung disease and kind of clumped together. We haven't studied this independently in interstitial lung diseases, so this data of who needs oxygen is extrapolated from COPD literature, and that is somebody who drops their oxygen levels less than 88% when you measure blood oxygen levels on exertion. So there are certain patients who may need overnight oxygen, early oxygen initiation, even if they don't have exertional desaturation. And we can test for those with checking the oxygen levels at night or performing a sleep study. And depending on when you're desatting or when your oxygen levels are dropping is when your doctor is going to tell you, you need to use oxygen at rest, you need to use oxygen when you're exerting yourself, or you need to use oxygen only when you're sleeping. How much oxygen do you need to use? And that's an important question because the amount of oxygen that you need can vary. It can go up and down. And a lot of time, the challenging aspect of scleroderma patients is I keep pointing at my finger to get the pulse ox, but that is not very reliable when it comes to patients who do have sclerodactyly. So we do have in our clinic the Nellcor that goes on the forehead, which is a little bit more. I have patients who use an actigraph that goes around the thumb. There are the earlobe ones are a little bit more tougher to get, and even those are sometimes unreliable. So a lot of the times, the reason that when you come back to see us in clinic, we make you do a walk test again and again is not because we want to make you make sure that you're still as active as you are. It's because it's one of the only ways that we can reliably see if you need more oxygen or not. And the last question I have put up is that something that a lot of my patients either are worried about but don't ask me, but I tell them, can you use too much oxygen? And the answer is no. So the lungs are not like the muscles in one sense that it is not use it or lose it. So if you use more than what you're prescribed, your lungs are not going to get dependent and they're not going to kind of stop trying. So a lot of the times I find patients kind of limiting what they're doing so that they can stay on the same amount of oxygen so that their oxygen levels are not dropping. But what I find is then they become less active. And that is a huge red flag for me because what can hurt you in the long run is that if you do need more oxygen, I want to know about it. And that means there is disease progression I need to know about. If you're not moving as much, that is also going to be a huge problem because we want you to be active. We want you to exert yourself. We want you to hold on to your muscles and your muscle strength, which is a good segue into what else we can do, which is pulmonary rehab. And pulmonary rehab is a graduated exercise program for patients with interstitial lung disease. It is monitored care with the help of respiratory therapists and physical therapists who will monitor your oxygen levels while they take you through an exercise regimen that slowly increases in intensity. It usually starts, there are 4 phases of pulmonary rehab. Phase 1 is what happens in the hospital. So a lot of the patients don't go through phase 1, but phase 2 to phase 4 is what you usually see as an outpatient. Medicare currently would support 36 sessions in a lifetime, but there are ways in which we can kind of improve or add to that with additional physical therapy that is pulmonary based to help patients get back in shape, kind of understand what their true oxygen requirements are, and kind of push them under a monitored setting to exercise more, be active, so that you can go out and do the things that you want to do. Treatment paradigms with regards to pharmacological, there are 2 different ones that we usually talk about. And the first one is immune modulation, and the second one is antifibrotics. So immune modulation, the data for this actually came from the Scleroderma lung study 1 and 2, the results of which are shown up here. So we know that treating patients with immunosuppressives who have scleroderma lung disease is beneficial. So the initial drug that was studied was cyclophosphamide, and then subsequently we compared it to a common drug called Cellcept. And both of them were beneficial. Only thing was Cellcept was associated with less adverse events and was more well tolerated than cyclophosphamide. We often talk about rituximab in a subgroup of patients understanding the risk of long-term immune suppression. Again, this is a big gun immune suppressant that can kind of suppress your immunity for 6 months at a time. The clinical trials that were done for this, there were 2 small trials that did meet some efficacy, but they were not large enough for it to make it to a big journal. They were all in rheumatology, I believe, which is a good journal. But the size of data, as you can see in this meta-analysis, is the sample sizes are very small, except for this retrospective study from 2019. So, but we do know that overall effects of rituximab is is helpful, and it is something that we sometimes use in disease that is progressive. The latest drug treatment that we have for progressive systemic sclerosis associated ILD is an IL-6 inhibitor called tocilizumab. This is part of the FOCUS trial that came out a few years ago. And here we are looking at the lung function trajectories in a group of patients who were on treatment as compared to those who were not on treatment. And what you can see is this is actually the data from the open label extension, which shows at one point when even within the folks who had placebo, who when they started on treatment, you can see some improvement and stabilization of this lung function, kind of similar or parallel to the ones who were treated. So early separation of curves with regards to lung function decline, and kind of finding that parallel with the open label extension group, which is, again, convincing evidence that this drug actually is helpful. Always, we try to counterbalance the risk benefit of any therapy. Tocilizumab is also an immune suppressant and can cause significant infection. So we want to be very selective about the patients who went into this trial. Do you represent that patient population, or is this the right medication for you? Are things that we take into careful consideration. Speaking a little bit about the antifibrotic aspect, this is, I'm going to talk a little bit about nintedanib. The common name is OFEV. This was studied in a scleroderma ILD patient. This is data from the census trial that looked at patients with scleroderma ILD and how they tolerated OFEV versus placebo. And you can see the decline in lung function was less with nintedanib as compared to placebo at 52 weeks. So OFEV has independent FDA approval for scleroderma ILD, but in other forms of interstitial lung disease with progressive fibrosis, we can use this as well per another data point that I'm going to show in the further down. There was a study that looked at mycophenolate and the pirfenidone combo. This one, you can see that the endpoints were comparable. Pirfenidone is another one of the antifibrotic drugs. These drugs were initially studied in another form of lung disease called idiopathic pulmonary fibrosis. It's a form of ILD. So that's why they were then used in scleroderma ILD and studied together. So this did not really meet an endpoint where there was no discernible difference. So pirfenidone is currently not approved in its pill form for scleroderma ILD. Mortality, if you look at how these drugs have changed the outcome, you can see that, with regards to immunosuppressants, you are actually seeing significant differences in mortality. Again, cyclophosphamide has a lot of adverse effects, and that you're seeing an increased mortality with that, which is why we are now looking at MMF, which is again at 20% as compared to cyclophosphamide was 22%. There is also selection biases that go into this. Stem cell transplant, again, you're seeing a mortality that was less, but stem cell transplant for scleroderma has its pitfalls, and it has to be, again, used in a select population. And stem cell transplant versus IV cyclophosphamide, again, the impact, the amount of mortality, we are seeing mortality in at least a fifth to third of the population. And that is what I want to impress here. This, despite drug advances, we are still seeing significant burden and mortality from this disease. We do have systemic sclerosis associated interstitial lung disease guidelines that were developed by the ATS. And this is one that Dr. Silver is a lead author on as well. And currently, as the guidelines stand, looking through all these data, because again, like I said, this is a heterogeneous group of diseases with each individual varying significantly in disease pathology and disease trajectory. So there is this central group that looks at all the evidence and kind of comes up with best practices. And from the ATS standpoint, we know that CellCert is associated with benefits with low risk, and that is what the one has strongest recommendation and conditional recommendation for some of the other agents that you're seeing: cyclophosphamide, rituximab, tocilizumab, and nintedanib with mycophenolate. And the ones in gray are not recommended for clinical use and should be studied in terms of a clinical trial. Again, this brings us back to kind of contrasting it with the CHEST guidelines, which also have similar recommendations. However, they group mycophenolate, tocilizumab, and rituximab all within the preferred first-line therapy as compared to the ATS, which preferred mostly mycophenolate. And these guidelines also give us a rubric of escalation of treatment depending on progression as well. Progressive pulmonary fibrosis, and I'm going to touch on this very briefly, is a subgroup of patients who may have overlap syndromes. They may not have true systemic sclerosis, ILD. They may have some sort of mixed connective tissue disease, a combination of dermatomyositis with scleroderma. Those were populations that were excluded from the census trial. But we have another trial that actually looked at patients from all forms of pulmonary fibrosis, and that's what this shows. There is the subgroup of patients with that behavior of progressive pulmonary fibrosis within multiple disease groups that was studied, and we were seeing some benefit. And again, this is from the same paper that I showed earlier, showing you the heterogeneity in progressive pulmonary fibrosis that you're seeing with regards to a fourth of the patients doing well with stability, then subsequent subsections showing intermediate decline versus steep decline. And that's what these numbers are showing in the green to red bricks. And this is the breakdown, or kind of like a form of alluvial diagram that shows how things have turned over proportion-wise from year to year. This is the in-bill study that I was referring to, and these were all comers with a specific cutoff for progressive pulmonary fibrosis that was defined using clinical, radiographical, and PFT domains. So there are multiple ways in which you ascertain somebody has progressive pulmonary fibrosis. And this is another reason why we want to check your lung function test at least every 4 to 6 months, just to make sure that your lung function is stable, because one of the ways in which you're saying that you have progressive disease is by seeing a difference in your lung function measurements, in addition to your input telling me that you're not able to do the same things that you could do last time. You're more fatigued, or you're getting more short of breath with stuff that you could do without any trouble even a few months or a year ago. So this is where I want to take a break, I think. Yeah. So unanswered question, and these are questions that I put them as unanswered questions because I don't have the answers to them. But these are common questions that I get in my clinic. Who will progress, right? And to date, the data just shows us risk factors. Folks with diffuse cutaneous subtype of systemic sclerosis, folks with presence of anti-SCL70 antibody, male individuals or men with systemic sclerosis tend to progress faster, and they have a poorer outcome as compared to women. When will progression happen? Again, previously we thought it was within the first 7 years. Now we know that data is not as clear, and we have seen progression even later on in the disease course. At what rate will it happen? Will it always progress in a linear rate, in a predictable manner? That is also not true. We see patients who have progression either as a response to what we do to it, versus people who sometimes choose not to have additional treatment as well. We can see kind of the progression kind of slow down on its own, but there is no way in which we can kind of tell you, is that what's going to happen, or do we need to consider up-titration of treatment or change in treatment? And is there something to help predict this? And this is kind of something that we are actively working on, like molecular signatures of telling who is going to predict. Is there is your specific genetic makeup, is your specific the proteins in your blood, are there chemicals that we can identify kind of clump together to give us a signal as a predictor of this progression? There is active work that's being done on this front. So I'm going to conclude in a little bit of talking about what's new at MUSC. So Dr. Silver and I, we're understanding the large population of autoimmune interstitial lung disease that we see at MUSC. We do have a new combined clinic at the Health West campus. We have it, for the time being, we have 2 clinic sessions a month on Monday afternoons, but I'm sure we are hoping to expand on that. I have a Chess Foundation grant to study the role of sex in pulmonary fibrosis. Again, as I had mentioned earlier, men tend to do poorly. And we don't know why. Even if you account for, biased exposure risks, like men tend to smoke more, men have occupational exposures as compared to women. Even after accounting for that, we see that men tend to have poorer survival as compared to women. And the reason that evokes interest in me is then, well, is there something in women that we can try to replicate or try to modulate, or try to kind of accentuate, to kind of help treat this disease? And we also have, with the combined clinic, we also have the opportunity, in addition to the portfolio of ILD trials, we have more and more trials that are going into the SSC ILD realm. Previously, as pulmonologists, everybody, as pulmonologists who specialize in pulmonary fibrosis, everybody wanted to do trials in idiopathic pulmonary fibrosis, which was, again, a little bit more predictable disease, but that has changed over the past 10 years, and there is an expanding portfolio of trials studying scleroderma lung disease. So lots of work to be done. What we have, again, is we're excited that we have an ILD biobank. These are patients with connective, any forms, not just specifically systemic sclerosis, but any forms of connective tissue ILD. We are banking blood, enrolling these patients and following them prospectively. The idea is then we look at the molecular signatures to kind of help predict and answer some of these questions that I had put up a few slides ago. We have a database that looks at anybody who has been seen within our clinic from 2014 onwards. So we are compiling data to see how our population is doing and kind of compare that to what the rest of the world is putting out there. Sex as a biological variable is what I had briefly talked about. And then an increasing host of clinical trials. The reason that I included the progressive pulmonary fibrosis bit was because there are medical companies that are interested in studying this. So as you can see, as of now, we have 4 different trials looking at for this condition of progressive pulmonary fibrosis. The one in light blue are the ones that are planned globally or are starting out globally. We are not an enrolling center yet for those. And further down on the last one is the clinical trials anticipated at MUSC, which is on the National Scleroderma Foundation Conquest platform, which is an adaptive trial platform with 2 of the drugs. Octilia, again, an NIH-funded study, and darsimelagon, which is also going through a phase 2 trial at the moment for scleroderma ILD. That's it.